Now, if you want to talk from the beginning, you all are from 38 batch. Are you all?
Yes, sir.
Right. So if you go back to say 20 years back, so 17th, that's my batch. Okay, 17th batch, and from University of Pune. And let's talk about neurosurgery. Yeah, we'll start from brain tumors. Uh, can you see my slides now?
Yes, sir.
Now actually I do these things like a discussion with you all. Now since I can't see you all and I can't get your feedback as we do in natural or real time real lecture theater, I'll talk, and but you all can interrupt me at any point, and if you have any queries, you all can discuss with me. Okay? Can I switch off this place? Now, uh, let's go to the other slide. Now, if you talk about the epidemiology of brain tumors, it's not that uncommon. It's you see about 20 per 100 population. And as you all know, the commonest tumors are metastatic tumors when you go old. The structures due to primary or the secondary brain tumors, metastatic tumors, the commonest primary tumors are breast, thyroid, prostate, and commonly lung, and sometimes kidney. Now you know this classification: primary and secondary. The secondary brain tumors are the commonest, whereas the primary is not that common. So, do you see these slides?
So we can see. So can
Can
you
you
put
see the slides?
if that's possible?
Hello.
So we can see, sir. Can you put the presentation view if that's possible?
Pardon?
So can you put the presentation view, the full screen view if that's possible for the
Full screen.
slides? Yes, sir.
All
Thank you.
right. Yes, hold on. Is that what you want?
Yes, sir. Thank you, sir.
All right. Good. Now, uh, you all must have heard about these conditions like rare conditions, neurofibromatosis, NF1, NF2, uh, tuberous sclerosis, von Hippel-Lindau syndrome. These are genetically determined disorders. These people with these diseases, the patients with these conditions, they have high chance of getting brain tumors. And the retinoblastomas, gliomas, meningiomas can have familial predisposition. And racial, I'm just talking about this epidemiology. Now, some tumors are common in Africans, CP angle tumors, and there are ectopic tissues like cranioparenchymas, teratomas, dermoids can happen in brain. And as you all know, the tumors can have age, sex distribution. Some tumors are very common in childhood. For example, medulloblastomas, cerebellar tumors like posterior fossa tumors, astrocytomas. Meningiomas are common in females, and whereas the gliomas, high-grade gliomas, are common in males. These are, I'm just giving you a basic idea of distribution or epidemiology of brain tumors. And if you talk about the risk factors, there was a belief that trauma, head injuries can give rise to meningiomas, but that has not been proven. But clearly, radiation can have predisposition to tumor. If you talk about which year you all are now?
Fourth year, sir.
Pardon?
Fourth year, sir.
Both. So you all have done the pathology and microbiology.
So pathology is still going on, sir, because those lectures were put during this period we were at home.
Right. So fourth year means, have you all done this the microbiology and parasitology exams you all have completed, I suppose?
Yes, sir.
Right, right. And you're sitting for pathology, forensic, community, and pharmacology.
That's right, sir.
Right. So when you talk about the tumoral genesis or risk factors for tumors, you can have genetic, environmental like radiations, chemicals, and all these things can happen in brain tumors. So radiation can have sarcomas and sometimes meningiomas. Some chemicals have some risk for brain tumors. Infective agents, the commonest thing is, I mean, HIV. HIV can have CNS lymphomas. So the clinical presentation, I mean, apart from epidemiology, the most important thing is as clinicians, we all should know about how do they present. Now, one of the common presentation is diseases. So if you get a patient who presented with first time disease, you must always in your back of your mind you should think about, okay, could this be tumor? Okay, could this be brain tumor? It may be normal, it may the chances of it may not being a brain tumor is very high, but you should not miss the serious condition. You got my point, no? So, the diseases or the fits can be maybe focal seizures, only the hand movements or the facial twitching, or generalized tonic-clonic seizures, or like absence seizures. Do you know about the absence seizures?
Yes, sir.
What is absence seizure?
There's no motor component, but there's a time period where that person like has like some visual um,
Very good. Yeah, yeah, yeah. Just staring at. I mean, he doesn't know what's
areas.
happening outside, but you don't see like tonic-clonic movements. Good. In and now we are talking about the seizures in otherwise healthy individual. Even the people who known to have seizures can have brain tumors, no? So how do you recognize them? I mean, they are always they I mean, they are known to get seizures. But if you notice that their seizure pattern is changing, then you must think about something happening inside the brain. For example, I mean, we are talking about the guy with absence seizures, and all of a sudden, if he started generalized tonic-clonic or focal seizures, then you should think about, okay, this is something going on, because the idea of suspecting a lesion is the key things to order a MRI scan. Okay, and like adult onset seizures, always we should think about something serious inside the brain, not like young people. So, I mean, seizures are due to intrinsic electrical discharge or abnormal discharge inside the brain, because of the tumor related inflammatory condition. Now, headache is also a common feature of brain tumor, and you will see like throbbing headache. um it's very distressing, and it's a continuous headache. It won't respond to simple analgesics, and you may not localize the exact side of the headache because it may be all around your head. And the one of the common thing is how these headaches are more common in morning, early morning. We call it early morning headache. Does anyone can explain why you get early morning headache in brain tumors? Hello, hello, hello.
So we are there, sir. I don't know the answer.
Can you hear me?
Yes, sir, we can hear you.
What would happen during morning? Okay, let's go back to before morning. It's a night, no? No. Just you all should think. I mean, the problem is you all just, I mean, enter to the medical career soon after doing A level, where you feed the subjects. You get fed by the tuition masters, and you will not explore your brain. No, so you don't want to think. I mean, you don't, you just try to grab what you been told or what you've been taught, and that's not enough. I mean, you're going to be doctors and make decisions on your own. So think. So what's happening during night to your brain? Anything happen? What do you do during night? You sleep. No, everybody sleep. When you sleep, what is the position of your head? Hmm? It's in a horizontal position. No, it's not propped up. It's not upright. You are not upright. You. So when you are not upright, your your head is in a lower or the rather horizontal level. The gravity effect on your brain matter is more. That is why if you measure, if you now in our hospital we have this ICP bolt or intracranial pressure monitoring system. We may in head injury patients we make a small hole in the skull and pass that catheter and then connected to the you know the multi monitors, so you can measure the brain pressure. Okay, so when you measure the brain pressure, if you keep the patient propped up or 45 degrees angle, your pressure is low. Whereas if you put the patient head down or low, your pressure readings goes up. Okay, so the gravity effect on your brain. So same thing happen when you do sleep. You more fluid or more congestion in the brain. So that is why people with slight brain tumors or beginning at the very beginning, you have more symptoms on the morning than towards the end of the day where you are standing throughout your daytime. Did you get? Am I confusing you all?
No, sir, we understood.
You all understood, no?
Yes.
Yes, sir.
Right, good. Now these are things that you all to think. So uh, so headache is an early morning with nausea, vomiting, one of the common feature of this thing. And vomiting is probably due to irritation of the vomiting centers in brain stem, medulla oblongata, and not like the vomiting due to gastrointestinal problem. You may not see the vomitish feeling or sick, like you feel aura like thing in gastrointestinal condition. But in this case, you may not uh, feel that. You just uh, vomit it. Okay. Um, and then papilledema. The you all know what is papilledema. Have you all started your clinical appointments?
Yes, sir.
Yeah. Have you all done neurology or medicine appointment?
Yes, I think most groups have done their neurology as well. Medicine first appointment we have done.
Right. Very good. How, has everybody look at the patient's fundus by using the ophthalmoscope? Hmm? At least have you all seen the pictures of the optic fundus
Yes, sir.
in your textbooks? So next time when you'll go to the ward, I don't know whether it's out of bound for you all now, but get the ophthalmoscope from your ward sister in charge and look at the eyes. And once this COVID season is over, but if there is a COVID suspicion, you don't go close to them. Be safe. But if not, look at the eyes. And there are a lot of things you can see in the optic fundus. No, those days before the MRI or CT era, that is how people diagnose most of the conditions. So know about the signs and symptoms, peculiar things what you can see in the fundus. There are many signs. Okay, optic hemorrhages, optic edema, uh, pale disc, and vascular pulsation, diabetic changes, loads of things. If you talk about optic disc, so your job is to see the optic fundus in each and every patient, and if you all know any one particular patient who got this optic neuritis, so a papilledema, let others to see and identify. I mean, be familiar with how it's seen. Okay, those days I can remember when we were in medical student in same university, same medical faculty, and same boards like you all. Those days, sisters, they were trying to chase us out of the wards because we were always in the ward. We carry this ophthalmoscope, look at all the patients from one end to the other end. And if somebody with abnormal signs, then there is a whiteboard in the student room. Do you all have those things?
Yes.
Yeah, and we mention their name and bed number, then everybody can take turn and see the patient's condition or elicit the signs without disturbing the patient. So think about be familiar with the papilledema. I still see each and every patient. In all my patients, I do examine myself and I look at the fundus myself. And it's very important. And sometimes you can see retinal hemorrhages and visual field defects uh, are not uncommon with brain tumors. So frontal bulge in the very small kids, the frontanels. You have anterior frontanel and posterior frontanels, and the frontanels can bulge if you have brain tumors or obstruction inside. So that's one of the sign you can see in pediatric patients. Proptosis can be, if you talk about the proptosis, the commonest thing comes to your mind is thyrotoxicosis. But don't forget, if you have tumor inside the brain or orbit or close to the inside the brain, can sometime have proptosis. Diplopia, double vision. The reason for double vision, it's usually palsy of one of the nerve, either abduction or the nerve, or yeah, sometimes the trochlear. And the nerve supply of the eye. Examination of the eye is one of the very important role in a neurological examination. You look for the pupils, size, reactions, and there are different pupil reflexes, which you all should know when you do the neurology appointment and do the clinical examination. Because these things I might ask in your exams, because unfortunately I'm coming to your exams every year for surgical exam, but I don't come to medical exams, but surgery I do come. And I might ask if you have patients like this. So, uh, so the proptosis, diplopia, and disturbance of higher function or psychiatric function or concentration memory, very common. I have seen some patients who've been treated in psychiatric ward, and they are not responding to the antipsychotic drugs. And later they do, either they refer to us, or when they do the brain scan and MRI or CT, you see a tumor or bleeding, blood clots, SDHO, some chronic tumors like meningiomas. It's not that uncommon. So keep that in mind. If you that doesn't mean everybody with psychiatric symptoms have brain condition, but medicine is art, so everything you can have combination, but there should be some reason for one to get sick. So always have many possibilities behind your head when you see a patient, and try to narrow down your diagnosis. So the endocrine changes, Cushing syndrome, acromegaly, and you can remember the pictures in your textbook, like and yeah, prolactinomas. So when you have pituitary tumors, the visual field changes by temporal hemianopia or unilateral quadranopia. Anything can happen, any kind of visual defects. And do you know the examination of visual field things? Hello?
Yes, sir.
Yep, the confrontational techniques. No?
Yes, sir.
And the way you all do, because these things we do ask in exams. And then systemic changes like blood pressure changes, hypertension, bradycardia, Cushing reflex, it could be terminal thing if you have high increase intracranial pressure, because patient with Cushing reflex, that is a terminal event. Like sometimes the pulmonary changes can happen. So focal neurological signs like weakness, paralysis, and those are called localizing symptoms. So for example, the commonest things you have right side motor cortex tumor, you have left side arm more leg or face weakness. Like that, you can localize. The beauty of neurology is uh, with clinical history and examination, you can locate the lesion, either spinal cord, either brain, wherever, which part of the brain, and even the what type of lesion it is. It's a ischemic lesion, vascular lesion, or inflammatory tumor, or degenerative. Like you should be able to localize and make name what type of tumor it is. So be very familiar with the thorough with the neurological examination. That's very important for your lifetime. Uh, so do you know the a book called Neurology in Short by Professor J.B. Pierce? If you'll have, just try to find it out and read. One of the senior neurologists. He has written that book, how to uh, identify the lesions in neurology. So false localizing signs are the different signs which you will have to learn. And brain tumors, I mean, the best classification for brain tumors are the WHO classification, but it's very hard, very descriptive. I mean, I don't recommend for you all to know about the WHO classification. For us is okay, but for you all, don't work on that. I mean, it's very difficult. But for you all, if you know about the in cellular basis, like primary tumors, secondary brain tumors, primary tumors are gliomas, and under the gliomas, astrocytoma, oligodendroglioma, ependymoma, medulloblastoma. These are all, if you know, these cells are the supporting cells of brain. The real brain tissues are the neurocytes. So the neurocytes itself very rarely can give rise to tumors, because as you all know, the neural cell line is one of the end cell line of your trigeminal plate ectoderm, because once it committed to become a nerve cells, nerve cells won't regenerate, or nerve cells won't multiply. So primary neural cell tumors are very rare, but rarely you can get what you call neurocytomas. That's not that common. Uh, but all the brain tumors like astrocytes, oligodendrocytes, ependymal cells, those are brain supporting cells. Okay, so these supporting cells can give rise to tumors. So if you suspect a patient that the patient like we discussed, and then we must go for the investigation. Now, you know the CT, MRI, then positron emission technique, tomography, PET scan, spectra. We have a lot of tests, but out of those, the test. Now, the difference between CT and MRI, you all should know. I mean, CT is very quick. You can just do that. But it carries a risk of radiation, and the CT good for head injuries, which we will discuss it some other day. But if you suspect a tumor, the best investigation is MRI contrast enhanced, because MRI, it takes time. If your patient has, say, metallic implants like cardiac, the cardiac, what do you call, pacemakers, or any electronic gadgets inside your body, then you will not be able to do MRIs. Sometimes metal plates, bone fixation are contraindications, but new techniques are available, if you have the fixation with the titanium, you can do MRI. And one of the another contraindication for MRI is if your patient is claustrophobic, because have you all gone to your MRI department in your hospital?
Yes, sir.
Have you all done the radiology appointment?
Yes, sir.
Good. Now you know the MRI works on high magnet field, and you should not carry any metal or magnetizing devices inside, and patients should not be claustrophobic. And the MRI scan takes time. The investigation itself take about 40 minutes, 20 minutes, like it's not as fast as CT. And but if you suspect brain tumor, please go for MRI, not the CT. The PET scan, SPECT scan, those are very, I mean, the high-end test for only for specialized, in specialized centers for special patients. We do have these things, and we do very rarely. So this is one of the, I mean, I don't know whether you all can see the difference here. Now you see the normal gray matter. These are normal gray. This is uh, one of the vein, and if you see there's some difference here, like a swollen part, and this is a part of the tumor, brain tumor, intrinsic brain tumor. Um, and if you see MRI, now this is the MRI, these are coronal images. You see a brain, and you see this hyperintense lesion. The term used in MRI you call hyperintense. You don't call white black like that. Okay, so this hyperintense lesion here, like you can see the brain is pushed to the opposite side, and compression of the brain matter, like cortical matter. So obviously, if this is, so this seems to be left side, then obviously patient should have symptoms on the opposite side, right side motor symptoms. And you can see another tumor here. There's a lesion, probably again in the motor area. Now this side is usual right side, so patient may have left side weakness and diseases, so can happen with this tumor. So if you see post-mortem specimen, you can see the tumor inside. Um, and this is again another specimen, pathological specimen, where you see the tumor. You can see the difference in cross section. So there are tiny, the red color areas are because of the bleeding, and you can see the midline pushed to the opposite direction. So the treatment or management, and obviously when you talk about the brain tumor, most of the time these people end up in theater or the surgical operation, either to complete removal of the tumor or do we do biopsy. But we always try to, we most of the time we try our level best to remove completely tumors, so that at least patient can be cured or near a cure level. But there are lesions which you cannot take completely. For example, brain stem tumors, lesion in the thalamic areas, deep white matter tumors. So those kind of tumors which are not surgically amenable, we do biopsy. So before go to theater, there is a kind of a ward preparation for these patients. Most of the time we use steroid to reduce the tumor-related edema. And if the patient had been on aspirin, clopidogrel, or warfarin, we need to stop those things before any surgical procedure, because if it start bleeding during the operation, it's very difficult to control inside the brain. And patient should be nutritionally good hemoglobin, platelet count should be normal. And we do have biopsy techniques called stereotactic biopsy, that can be done under general anesthesia or under local anesthesia. And it's like a day procedure. You pass a needle, make a small hole in the brain and pass a needle and take a biopsy. Or else we do craniotomy and excision. We make a opening of the brain on one side of the skull, not completely, of the, depend on the size of the tumor, and we remove the tumor. Now this is stereotactic biopsy frame, and now you fix this frame to head like this. This is the schematic diagram, and then you can have needle here, make a small hole, and pass a small needle and take a biopsy. And before you go for a craniotomy, you must always say, for your patient going to have a neurosurgical procedure, removal of brain tumor. Now, the most important thing is you must relieve or make the patient calm and quiet and leave the anxiety away. Because I mean, you can understand if somebody says, okay, you are going to have brain tumor and you are going to have brain operation, you can understand the anxiety or the fear of the patient and their relations. especially if that is going to be a kid, then parents feeling you should understand. The most important thing is you must speak to relations, tell the truth, and be nice. Try to understand their problems. Okay. uh, and consent for the operation, like you explain the risk and benefits of the operation. And then once you discuss the pros and cons outcome, then you get the consent. And not like the other part of the body, I mean, you have hair always, so unless a bald patient, I mean, you need to shave the hair, but not in the ward when you inside the theater. And the identification of patients inside the theater is very important, because they say if you have breast lump, just before anesthetizing the patient can say, okay, I have breast lump in my right breast, or I have breast lump in my right thigh, or right hand, like that. But your patient won't be able to tell, oh, I have tumor in the right side of my brain or left side of your brain, because either patient conscious level may not be that good, or we be diagnosed by the images. So correct identification of the patient and the site of the tumor or site of the lesion is very important. And yeah, those are the most important. Now you all going to be what house officers first line in your job, and these are basically your part. And make sure these things are correctly done before you send the patient to theater. So as I mentioned, I mean, not all tumors need to be excised or removed. Some tumors we can left alone. So say if you once you remove the tumor and you send this patient for histology, and you close the skull, close the skin, and stitch them and recover the patient. And it takes about say 10 to 14 days to you to remove the stitches and send the patient home. And when you send, and then you get the histology report or the biopsy report. And if turn out to be a cancer, malignant brain tumor, then you will face another set of problems. You'll have to break the news. So you will have to tell the patients, okay, I have removed the tumor and it's not a good tumor. You need to have another set of investigation or treatment. So in that case, we use the term called multidisciplinary team. You have several disciplines like oncologist, uh, the pathologist, and neurosurgeon, and most of the time general practitioner or care giver. And then we decide what is the best treatment for this patient, like chemotherapy or then radiotherapy. And we'll have to do regular scans, like that. Maybe we have to do hormone replacement if you do pituitary tumor, like that. So there are, it's, I mean, just removing the tumor may not be enough in some of the cases, but most of the cases it is a treatment. If you have meningioma, you just remove the meningioma, that's it. But if it's glioma, you remove that and then you go for adjuvant chemo radiation. If you have pituitary tumor, you remove the tumor and then you have to give them with the hormone replacement, like that. It's not a, it's a combination, or it's a kind of a package with different disciplines. And as I mentioned, providing information and support to the patients very important. You alleviate their fear, and we refer to the specialists as soon as possible if they develop any other worsening of symptoms, and tell always a natural history of the disease, like this is what happen if you don't treat, like. And it's always, I mean, what I'm trying to tell in this slide is always try to make a good rapport with your patient. Tell the truth, tell what you can do, and tell what is available in our country, or tell what is available in the world for the patient's condition. Where people like to know what is possible on this earth. Like tell always truth and tell what you can do, and do your best. And yeah, so that's it. And I think now, hello, hello.
So we are
Yes,
here,
sir,
sir.
we can hear you.
Are you sleeping or not sleeping?
Yes, sir.
No sleep. Very good. Right. Now, I think Dr. Kumar Singh wanted me to do brain neurosurgery, head injuries as well. What I'll do is I'll fix another day. What are the dates you all can do? Hello.
So we usually have lectures like throughout the week. If you tell Kumar Singh, so maybe you check with the batch rep and the times we have the other lectures.
Yeah. I think the daytimes is not possible with you all as well as me because I'm working in the hospital. So I'll spend some time in my weekends with you all, and I'll discuss about the head injury and the commonest things like back pain, neck pain. Those are the common neurological or spinal conditions which you all come across during your practice. And head injury, of course, you all should know in and out. And anything else you all are interested? Maybe I can prepare for myself. Hello? Hello? Can you all hear me?
Yes, sir, we can.
Yes.
Anything you all want me to do other than head injury and back pain, neck pain? Those are the topics those are the topics which I do for Colombo students in medical school. So I thought I should do the same thing with you all. Anything else you all want me to do? Hello?
Demyelination diseases like
Demyelination with the multiple sclerosis.
Yes, sir. Guillain-Barré's disease syndrome.
Guillain-Barré, yeah, those things are actually neurological conditions. So that should come under neurology lecture. Now, actually, my job is neurosurgery. I do operation. So I will talk about, I'm a surgeon, so I will talk about only the things which I can help, like I can cut or chop or repair or do something. But the Guillain-Barré or MS or multiple sclerosis, then there's no place for surgeon. Just you give 1 or 2 drugs and that's it. No, I mean maybe you have to ventilate the guys. Yeah, just have your time. Think about that. You can pass through your request through your coordinators or through Dr. Kumar Singh. I'll stop for today and we'll talk head injury, neck pain, back pain, and you might heard about the condition called normal pressure hydrocephalus. Maybe you can read on that before we come to the lectures. And yeah, this thing is you just read about head injury, spinal injury, and back pain, neck pain, and the condition called normal pressure hydrocephalus. And we'll discuss those things over the next maybe within next 2-3 weeks. Okay.
Okay, sir.
Right. Good. Right.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Right.
Thank you. Thank you, sir.